So first thing we'll look at is the patient history. So you can see this patient, 8 years old, when she first presented, and her chief concern was crowding and that the bite was off. And so this patient was referred from her dentist, and those were the concerns that they were made aware of when the dentist had sent them over. So medical history, overall, nothing too complex medically. Brodsky 2, just slight enlargement of the tonsils, and a nut allergy. Everything's current vaccination-wise, no surgery or trauma history, and all growth milestones are met. This is the sleep disorder breathing risk questionnaire. So if you go into, it's Axiom you guys use, right? Yeah, so there is a sleep questionnaire already in Axiom, and it's basically the same questions. So you can ask those questions, make sure you get all the answers, and then you can present it in some way visually depending on what Axiom allows you to do. But you can see here with this patient, not a lot of airway concerns. Some grinding of the teeth. It could be airway related, could also just be transitional dentition related, bite related, so not really sure there, but good information to know. And then a dental history, so low caries risk overall. There's some congenitally missing teeth, which we'll look at later. No history of orthodontic treatment, and there was premature loss of the maxillary left primary first molar. So then what we'll do is we're going to go through all of the individual photos like we normally do, and we're going to go one by one. So we'll start out with the frontal rest view photo. So when you guys are looking at this photo, what stands out to you? What are the things that you notice? What's good? What's not good? What's ideal? What's not ideal? Looks good. All right. All right, we've got one vote for looks good. All right, so does everybody vote everything looks good, or does anybody vote anything could be better or maybe looks different? So which side? To the right. Okay, so patient's chin to the right. Do you guys see that? Okay. I thought you were critiquing the photo. Photo looks good. I'm glad. I'll let my records tech know they did a good job on this one. So a little bit of chin deviation to the right. So not knowing anything else, why might that happen? What are some reasons that could happen? So I think you said a shift and a skeletal asymmetric growth. Okay, so could be a shift, probably most likely to be a shift, right? But could also be asymmetric growth. Asymmetric growth could be caused by a shift. If it wasn't caused by a shift, what else could it be caused by? Trauma, right? So if you have damage to one of the condyles or resorption of one of the condyles associated with trauma typically. What else could it be associated with? Could be some sort of a hemifacial thing. I mean, in her case, it's not, right? I mean, you would see more signs there, but asymmetric growth, again, could be associated with some sort of hemifacial microsomia or condylar hyperplasia, right? One side of the condyle grows larger. Again, we'll look at the imaging, and it'll help us there, but all these things can be going through your mind when you detect that midline shift. Anything else that you notice that is not ideal or could be better? Or is it looking pretty good? If you have trouble seeing those chin deviations, you can draw lines on the photos. And again, you need to orient your photo correctly, right? Because if your eyes or if your photo is taken at an angle or it's not oriented correctly, these lines aren't going to do you as much good. If the photo is taken correctly, you can evaluate the symmetry of the face overall, and it becomes a lot more obvious when the chin is deviated, when you can see it between those two lines. So let's go to our smile view here. Okay, so what do we notice about the smile? What are some things that are standing out to us? What's good, what's not good? What could be better? What do you like? Still waking up. How about Smile Show? What does that look like? Okay, I mean, if anything, we got a little extra space in the middle. That never hurts. What about the upper midline with the facial midline? How does that look? Looks pretty good. Yeah, pretty much right in the middle. You can't get an exact view of the lower midline, but can you see it there? Where is it? Looks like it's off to the right, okay? And why is it off to the right? Yep, you can see the associated Ceph. You can see the crossbite on the right side there. How about how broad is the smile? How would you describe that? A little bit more narrow. What are you noticing that makes you think it's more narrow? You see the buccal corridor is pretty dark there, right? Okay, so now we have this shift, hopefully, to the right side, crossbite on the right side that we're seeing. Smile show seems to be pretty ideal, but the buccal corridors are pretty narrow. You can draw lines on these photos to evaluate the facial thirds. Overall, pretty symmetrical. They have to be biting down, of course, to evaluate the lower facial third, which she is. So if you had to describe the lower facial third, would you describe it as completely normal? If you had to pick between shorter or longer, what would you pick? Yeah, possibly a little bit longer. We'll get a better view on the Ceph, but definitely not a shorter lower third of the face, which adds up with our incisal display, right, and the amount that we're seeing there. Let's take a look at our profile. What do we notice here? What's good? What landmarks are we checking? Okay, nasolabial angle. All right, so how does the nasolabial angle look? What's that? It does look obtuse. Now, is that concerning, or is there another reason it's obtuse? That's true. So younger patients tend to have a more upturned nose. As they grow and develop, it tends to come more down. And so younger, you would expect it to be a little bit more obtuse. Assuming this photo was taken in a natural head position, then how do you like the upper lip and the fullness of the upper lip? Not bad. Looks pretty good. All right. So what do we think about the mandible? What do we see there? If you had to describe it as like mandibular deficient or mandibular prognathic, if you had to pick one of those two, which one would you pick and why? Okay, possibly a little bit more retrognathic, you said at this point. So why did you point that out? Yeah, so we'll tend to see a little bit of mandibular catch-up, especially around the time of puberty. So could be within normal limits, and she's just not grown yet. What other soft tissue things can you look at to evaluate where the mandible might be, or AP-wise? Yep. So we look down here, right? Down here. Does that look, if you had to say shorter or longer, which one would you say? Yeah, possibly a little bit shorter. Okay. And then we talked about the lower third height on the other photo, right? That if anything, it was a little bit increased. And so when you look at this photo, what else seems to hint that maybe that lower third is slightly increased? Yep, you can get a sense of the wrong button. You can get a sense of the mandibular plane angle here, right? And even though we can't see the bones yet, it looks a little bit more increased there, okay? So we're starting to create a picture in our minds of what might be going on underneath. Now let's take a look at the photos. So when you upload your photos, try to get as ideal of a photo as possible. If you capture, and I believe I think you guys can do this on all your patients now, if you can capture a 3D scan, and if you can't, then you can create pour models and then take pictures of the models so that we can see clearly everything that's going on. So here we can see the recreation with the intraoral scan compared to the actual 3D photo taken. So what is standing out to you in these photos? What are some things that you notice? What's that? Yeah, so crossbite. Now, from everything we've looked at so far, why do you think this patient has a crossbite? Yeah, most likely a maxillary transverse deficiency, right? We noticed the increased buccal, the corridors were dark, and so if the maxilla is too narrow relative to the mandible, it's going to either shift on both sides or start severely decompensate. And we'll look at the decompensations more when we get to the imaging, the X-ray imaging. So one of the biggest questions we want to know at this point is the patient shifting, or is this where they bite down? Now, why do we want to know that? Why is that important? Exactly. So if this is where she's biting and there's no shift, then what we know is the jaw has already grown asymmetrically, okay? And expanding is not going to change that asymmetric growth of the mandible. But if she's shifting, especially significantly shifting, then we can be pretty confident that when we expand, that midline is going to go back over to where it started, right? So that would be more ideal. So what about our, what else do you notice on the photos? Anything else stand out? How's the hygiene? Yeah, not too great. I mean, it's the worst in the area where she's losing that baby tooth, and maybe that has something to do with it, just a little bit more sore brushing there. I mean, not terrible, not great. With the overbite, what does our overbite look like? Yeah, maybe a little bit deep, not too bad. Let's go to our center open view. Now, there's a couple pieces of information we can get from this photo, and that's why I always take this photo on patients now. One of the biggest things is you can easily document and check for wear of the lower incisors, right? Now, even though her bite's a little bit deep, we're not yet at least seeing really anywhere of the lower incisors, right? We still have all the mamelons on the top and on the bottom. Now, what's interesting is there is some associated wear on those primary teeth, and so, possibly at some point they were, grinding a lot. Doesn't seem to be affecting the permanent teeth yet, which is a good thing. This also gives you an idea of the curve of Spee, which may be contributing to your depth of bite, which is something typically we're going to address in a comprehensive phase of orthodontics, but worth kind of noting to figure out where you're going with the case as we go through things. So let's look at our right buccal photo here. Right, so we can see that cross bite is complete all the way back to the 6-year molars there. AP-wise, would you describe this patient as normal, more class 2, or more class 3? What's that? Yeah, pretty normal, right? I mean, not in a complete class 1 relationship at the canine, but we still have, the E-space. Those lower molars are going to tend to come forward a little bit. And so, we would look at this patient and typically say, okay, that's probably going to develop into a class 1 molar occlusion. Anything else from this view? How's our proclination of our central incisors? Would you say if you had to pick between proclined or retroclined? Yeah, maybe a little bit more proclined. All right, so looking at the left side, same kind of situation. So, wait, what was that? Go ahead. Agreed, yeah. So uppers look a little bit more proclined here. You can see them kind of tipping forward. Lowers look a little bit more retroclined. And, typically if the bite is deepening, then the lowers are going to retrocline, especially if there's room for them to do so with the loss of any of those baby teeth prematurely, and or if the lower incisors can tip backward before the other lateral lower incisors can come in. Left buccal photo here. Even though we have lost that maxillary left first molar, primary first molar, we've had some associated space loss, but not a huge shift to the left side. Still pretty class 1. If anything, maybe even slightly class 3 tendency. Now, why might this side be more class 3 tendency than the other side? What's that? Yeah, because of the shift, right? So if she's shifting, which it appears like she is from everything we've seen so far, then it would make sense that left side would be a little bit more forward, and it would present as a little bit more class 3 on the left side than the right side. And in some ways, that can disguise the amount of forward movement that we may have had with those upper molars and the space that we may have lost. So that's something that we're going to want to check. All right, when we look at our upper occlusal view, this is probably a better, and maybe that photo isn't cropped exactly correctly. Maybe it should be rotated, because I think that makes the space loss look exaggerated. I think the one on the left from the digital scanner gives a more accurate representation of the amount of space loss that we have. But either way you look at it, it looks like we have had a little bit of mesial drift of both the primary second molar and the permanent first molar there. Not terribly significant. It looks like that tooth was lost fairly recently, but certainly slightly. If we are to evaluate the crowding on this case, how much crowding would you say we have in this arch, and how are you determining that? So first off, we noted if anything, the centrals were a little bit proclined. So if anything, we're not going to gain any space from proclining them more, right? So we know that where those teeth are, if anything, it's going to require more space than we have, not less space than we have. When we look between canine to canine, she doesn't have her permanent lateral incisors in yet. She still has her primary lateral incisors. We've got maybe about 2 millimeters of space there. And so we're going to need a little bit more space for these lateral incisors compared to the primary lateral incisors. So let's just say that's pretty close to a wash between the space we have here and the space we're going to need here. Then that would tell us that at least on this side, we're looking pretty good, right? We have from canine to second molar, all those baby teeth are there. And on this side, maybe we're shy a millimeter or so. So definitely not a severely crowded case, right? Very, very, very minimal, like very, very minimal crowding. Maybe just a little bit from the space loss, and that's about it. All right, how about our lower occlusal view? Assuming we don't lose any more space on the bottom, then we should be fine between the canine and second primary molars. We should have room for the premolars and the permanent canines. And how do our lower incisors look overall? Also not bad, right? Maybe minimal crowding. Maybe there might be a millimeter or so. You can see a tiny bit of crowding and overlap of these central incisors. Maybe this lateral needs a little bit more space to come in. But what did you guys note about the lower incisors initially? Yeah, a little bit more retroclined. So we're going to be able to gain some space by bringing those forward as needed. Now, what else do you notice? What arch do you feel like has compensated the most as it relates to that shift of the lower jaw? So if the lower jaw is shifting, well, let's say the lower jaw didn't shift. So if the lower jaw wasn't shifting and the jaws were the exact same size that they are, you would either develop into a bilateral posterior crossbite, right, which would mean the lowers are more upright, or you would develop into a normal bite, but both the uppers and the lowers would be compensated. Lowers would be retroclined inward, and the uppers would be flared outward. So when we look at the lower arch, there's not really a huge amount of compensation that's showing up in our photos here. So when we go back and we look at the upper arch, what that likely is telling us is that what compensation happened? You can probably see it best on the intraoral photo here. Yeah, the right side has tipped inward, right? So the biggest compensation that's happened because of the shift is that the maxillary right side, the teeth have tipped inward relative to where they would normally be if the occlusion weren't dictating that. Okay, but not a ton of crowding to deal with. All right, so here's our Pano. We look at our Pano. We notice we have which teeth missing so far? Yep, lower left 5, upper right 5, okay? So now what treatment options might we consider for those missing teeth eventually? What are the basic options? Yep, you can maintain them. If you maintain them, what's the biggest obstacle you're going to have during comprehensive ortho treatment if you maintain those? Yeah, there's a big space discrepancy between those. So you either have to, and the discrepancy is not only at the level of the crowns, right? So I mean, if you were to, reduce the crowns, right, numb them up and just kind of like crown prep the tooth till it was as narrow as possible, you still have the fairly broad roots to deal with. So the angulation of the neighboring teeth are going to have to be different. Their roots are in order to fit together. So it creates an issue. It's not the worst issue in the world, but it's certainly, especially when they're asymmetric, lower left on one side, upper right on one side, it's going to be difficult to get those teeth to fit together very well if those are maintained. Okay. What's another thing you're going to want to pay really close attention to every time you see them as you're monitoring these cases with these retained primary teeth? Ankylosis, right? So if you see ankylosis and the tooth stops erupting, that's your sign to do what? Okay, extraction is an option, but if you extract on a 9-year-old and there's no permanent tooth, what would you expect when they're 30? Yeah, a lot of bone loss, right? So what might be a better option than extraction? Yeah, decoordination, right? So if you have ankylosis and the vertical is not, proceeding like normal, then you want to consider decoordination, right? In this case, of course, they don't look ankylosed at all yet. They look pretty normal, so no issues there. All right. Now, what's another option that we haven't talked about yet to deal with these missing teeth? Yeah, you can mesialize the molars. Now, in this case specifically, what would make that a good idea and what would make that not a good idea? Exactly. So we're not seeing developing third molars yet, right? So if we have a developing third molar, that makes a lot more sense to go ahead and start to mesialize, possibly extract those primary teeth a little bit earlier, let the lower teeth come forward. More recently, I won't extract the lower teeth earlier. And the reason being is that depending on how those teeth are extracted, you still can lose quite a bit of bone even while they're growing. So unless they're ankylosed, I will keep the primary teeth in there until I'm ready to start phase 2 ortho. Because what I've found is that when the bone loss happens and the ridges become narrow, overcoming that, let's say you extract it, and yes, the benefit would be, okay, well now the molar can drift forward, right? That would be great if it did. That would be the benefit if that worked. But typically it doesn't drift forward all that significantly, and what does happen is that the ridge of the bone narrows and hardens, becomes really dense, and then when I'm trying to move the whole body of the molar forward, it becomes much more difficult. And so waiting to extract those primary molars until you're actively ready to close that space is what we'll do now. The other benefit with doing that is you can put a brace on the tooth so that you can actually loosen that tooth before they go and extract it. So it's going to be a much easier extraction for the surgeon. The bone's already going to be more pliable in that area, and they're less likely to, extract the bone with the tooth when it comes out. But yeah, so, it's not that you can't bring those molars forward and not have a wisdom tooth there. It's just you're going to be missing a tooth in the back, right? So they're not going to have as much bite support. And so it's not as ideal of an option. So we're going to continue to monitor, see if this patient does develop wisdom teeth, and that'll help us make that determination. From a growth and development standpoint, is there anything right now that you're worried about that if we don't do anything could cause a problem based on the Pano? Like, are there any red flags here like, whoa, we better address this, or we're going to have, likely have problems later on? Is there anything else you want to keep a close eye on besides ankylosis of the retained primary teeth? All right, what else do we want to keep a close eye on? Okay, we want to keep a close eye on the canines. Which canines? Yeah, most likely in this case maxillary, right? I mean, mandibular, they're pretty much playing by the rules, pretty close to where they should be. They're already past the apices of the lateral incisors here. Maxillary canines, the tip of them is past the root of the developing lateral here, so that's good. Overall, the tip of the canine is in the spot that it should be. But we've also had this early loss here, and so we do want to keep a close eye on these areas and make sure that those canines continue to develop normally. Let me ask you this, though. If we did nothing and you had to bet all of your life savings, or, well, I guess maybe that's not a good example. If you had to, bet $1 million on it, do you think that there's going to be impaction, resorption problems with this case, or no? Most of you know, and I would agree. Yeah, so overall, again, we identified before, typically problems in impaction and things like that are relative to the amount of crowding within the arch, not necessarily relative to the amount of arch size discrepancy between the arches, right? So if you just look at the upper jaw as an isolated thing, there's pretty much enough room for those teeth in the upper jaw. But when you look at the upper jaw compared to the lower jaw, that's when that discrepancy starts, that's when you start to see the discrepancy between the jaws. Okay, so we're going to look at the Ceph. And obviously, like if you're not taking cone beams, then your Ceph is going to look different. So this shows us our depth of bite. We can see here that we initially thought our lower incisors were upright based on what we're seeing in the photos. Now that you actually look at that angulation on the Ceph, would you still say they're upright, or they're pretty normal? Yeah, pretty normal. So, I mean, if anything, maybe a little bit upright relative to where the lower jaw is, but that's probably in large part due to how more dolichocephalic and long lower third face that she is. So you can see here, the longer that the mandible is and the higher angle the case is, the more proclined the incisors are going to appear. And maxillary incisors, just slightly proclined, right? What's ideal? So as it relates to the facial surface of the maxillary incisor, what's ideal? Yeah, pretty much straight up and down, right? So you can see here, just slightly proclined, right? So if these were uprighted, you know, maybe a millimeter and a half, those central incisors would be pretty upright. All right, what else do you notice on the Ceph? Good, bad, or indifferent? Well, well, they're a vertical grower, right? We've identified that. So why might they be a vertical grower? What might be contributing to that? Okay, could be something, some sort of mouth breathing. It could be mouth breathing. Could be, what else? Could be a tongue, posture, or habit, right? What else? Well, any kind of habit, right? Could be thumb, could be blanket, could be something else. Now, we're not seeing a lot in the dentition that would indicate any sort of a digit habit, right? We're not seeing, you know, extremely flared. We're not seeing a space between the upper and lower incisors, but certainly could be open mouth. What else? What's that? It's kind of a big one we haven't talked about yet, and maybe it's kind of obvious, but maybe not. I mean, what contributes to all growth? In everybody. Your parents help out with it. Yeah, genetics, right? Yeah. So, I mean, like, you know, we have, to some extent, a predetermined pattern of growth, right? That's why class 3 runs in family. That's why class 2 runs in family. So, you know, possibly this could just be genetic, right? But when we identify these growth discrepancies, we want to start to think, well, why might that be happening? All right. Now, as it relates to, so when we look at the occlusal plane relative to the skeletal mandibular plane, how would you describe the occlusal plane? Is the occlusal plane more steep relative to the skeletal plane, or is the occlusal plane like more flat relative to the skeletal plane? Like this here, yeah. Yeah, it's a little bit more flat. Now, is that going to make it easier or harder to treat this case later in phase 2? What's that? Harder, probably? So, what do we worry about with skeletal, vertical skeletal discrepancies, dolichocephalic patients? What types of bites develop and what's hard to treat about them in general? Open bites, right? So we have, you know, basically this lower jaw growing down and back, the upper jaw is coming down, you start to develop interferences in the posterior teeth, and the bite starts to open. So the more steep that the occlusal plane is, the more that tends to happen. And so if you have a steep skeletal plane and you have a steep occlusal plane, that's more likely to develop into an open bite. So when the occlusal plane is a little bit more normal or even deep in your skeletal open bite cases, it tends to be a lot easier to get the teeth to fit together come phase 2 orthodontics. This is obviously a different patient, but if you have the ability to trace Cephs, that can be helpful. Obviously the Ceph here, I don't know how valuable those numbers are because you can see when they took the Ceph, the mouth was open. So pretty much every number is going to be completely off. But if you're able to trace the Ceph, the nice thing about that is it gives you the norms. So some of these numbers, you know, are legitimate, right? Upper 1 to SN isn't going to change with the mouth open or not. So the maxillary measurements are going to be pretty decent. Mandibular, of course, are all going to be off. But again, that can give you an idea of the standard deviation. So if you have the abilities to trace the Cephs, go ahead and do that. All right, here's the airway imaging. And this we've talked about a little bit before. So who can remember or tell me what would be considered normal or average for an 8-year-old as it relates to the minimum constricted area of the airway? What's that? Anybody? All right, we'll go 50-50. Who wants to say that this is more constricted than normal? All right, we got 1, 2, 3, 4. So the other 15 of you say it's bigger than normal? No? Just no voting. Yeah, so 8 years old, so typically 10 times their age in millimeters squared, right? So we would typically consider, you know, normal or average about 80. Now, this is not diagnostic in any way. We already took the sleep disorder breathing questionnaire. There wasn't a lot of signs or symptoms of sleep disorder breathing. So even though this is, you know, according to our radiographic norms, a little bit smaller than normal, that doesn't mean that there's a problem, right? It's just something, again, we want to make sure we're asking those questions. Could be that she swallowed at the exact moment the scan was taken. A big part, probably the biggest part that determines how big this looks is what? Posture. Yeah, head posture. So if the head posture is more back, it's going to look a lot smaller. If the head posture is more forward, it's going to look a lot bigger. So again, don't put too much weight into the airway film, but we use it as a screening tool. And if we see things there, this constriction is at the level of what? What is in that area where it's constricted? Really close. The other one. Tonsils, right? Yeah. So this is where the tonsils reside, right? And so adenoids are a little bit higher up here. We can see here it opens up, so adenoids don't seem to be problematic. Well, if we see this on this image here, maybe it's worth taking a look at the tonsils in cross-section and seeing, when her mouth is closed, how constricted is that? All right, TMJs. Here's our TMJ films. You can see right and left and front to back there. We're going to be looking for any abnormalities as far as erosive lesions or the development of the shape of the condyles. Is there anything that stands out to anybody here as far as what these look like? Any problems that they see, or do these look fairly normal? They look fairly normal. Now, what's another thing that we can check if we have a cone beam and we can visualize the condyles? What might this tell us as it relates to this patient specifically? Or what do we want to look at? What do we like? Oh, let me check this specifically because I saw this on this patient, so I'm kind of curious what this tells me. So what would we be looking for on this? Okay, wear pattern. Okay, so what kind of wear pattern would you want to look at? And what would you be suspecting? Because it's a good answer. I like the answer. But I want to know why and what you would check for. Okay, so two different things. Wear pattern. So the fully seated is what I was going for initially, right? So we were suspecting that this patient was shifting to the right side based on all the information that we had before. So when we look at this image here, we would expect to see the left side condyle where? More anterior, right? So when we look, and we're looking here, so anterior, posterior, all right, and these are different sections. You can see all the sections here. It's going all the way across. And so anterior, posterior, and then that's the right side. When you look at the right side compared to the left side, is there an obvious difference in the position of the condyle? No, there's not. Now, that doesn't mean that there's not a shift, but it probably means that there's not a huge shift, right? If that makes sense. All right? So maybe when we correct the maxillary transverse, that midline's not going to go all the way back. We'll see. Because if there was a really big shift, we saw our midlines were quite off, right? I mean, what, about 3 or 4 millimeters? So maybe not that entire, maybe the shift doesn't account for that entire thing. And that's why you want to couple your imaging with your intraoral exam and actually measure how far are they shifting to the side. The last thing we're going to check is the jaw widths themselves. And so this is how I measure jaw widths. This is a cross-section here at the level of the first molars. So you can see here the upper jaw is almost 40, the lower jaw is 45. What is your typical range for normal of the lower jaws in between the cortical plates at the level of the 6 molars? What is that measurement normally, or the range of measurements normally? 43 to 46. Okay, so normal lower jaw, 43 to 46. The lower jaw in general is very well preserved, right? So, I mean, we don't see a ton of deviation, but sometimes you do. You'll see less than 43, you'll see bigger than 46, okay? But normal is 43 to 46. So she's kind of like, lower jaw a little bit on the bigger side of normal, right? Toward the higher end of 46. Upper jaw, about 40. Now, what should the upper jaw eventually be in relation to the lower jaw in order for everything to fit as ideally as possible? 3 to 5 millimeters wider, right? So if we do the math here, we've got to do about, let's just say that's 40. So we need at least 5 millimeters to get to even, right? And then we need another 3 to 5. So we're talking about an 8 to 10 millimeter skeletal discrepancy, okay? Is there anything else we need to consider when we're thinking about that skeletal discrepancy? Or is that it? She's got 10 millimeters, we need to move the bones 10 millimeters. All right, we got a 50-50 shot here. All right, so who thinks that we need to move the bones 10 millimeters? All right, nobody? Okay, 1. All right, we got 2. 2, all right, 2 10-millimeter movers, all right? And who thinks we need to move the jaw more than 10 millimeters? All right, well, we're all in agreement there. So who thinks we need to move the jaw less than 10 millimeters? 1, 2, and no one else is voting. Okay, let's make the case for both. All right, why the 10 millimeters? Okay. Okay, is that? Okay, so there's growth, right? We're talking about an 8-year-old. So if we're going to measure the eventual jaw size discrepancy, we have to know how much Mother Nature is going to give us, right? So when we look at growth, we know that from the ages of 7 to 26, we're going to get about 4 millimeters of increased maxillary width with growth, right? We can break that down further, and we can see exactly when that growth happens, okay? So if you're looking at age 7, between 7 and 10, we're going to get 2 millimeters. So she's about 8, right? So maybe she already got like 2/3 of a millimeter or so. And so we know that we still have about 3 1/3 millimeters left, right? For simplicity of math, make it 3 millimeters. So really, if you subtract that off the 10 millimeter discrepancy that we have, now we have a 5 to 7 millimeter discrepancy, right? Depending on if we end up 3 or 5 millimeters wider than the maxilla. But that's really important because if you don't know what the normal growth is, then it's going to be very difficult to determine how your goals of maxillary expansion. Now, let's say we're shooting for 7 millimeters of skeletal expansion. How much should we turn the expander? What's that? 10 millimeters? Okay, so if you turn it 10 millimeters, then that would say 70% of your expansion would be skeletal and the other 30% would be dental. Is that typically what we see in the literature? No? Okay, what do we see? So basically 60-40 in a patient this age. But here's the thing, and this is where it becomes challenging, is that is such a loaded question, right? Because there's so many different types of expanders. Every patient is not the same. The resistance between the sutures is not the same. The anchorage, the amount of roots on the baby teeth versus the permanent teeth. In this case, you can see she's already lost one of the primary teeth, so that's less anchorage on one side compared to the other. And so hopefully one day we will have a very predictable formula for the exact type of expander we need and the amount of turns we need to affect the exact skeletal change that we're looking for. But right now, by and large part, we do the best that we can and we guess. So if you look overall, about 60% skeletal in kids this age, sometimes a little bit better than that, sometimes a little bit worse, depending on the design of the expander, depending on how fast you turn it. In general, shoot for the best anchorage possible and err toward faster turning over slower turning. And when I say faster, I never mean more than like 1 turn per day, okay? Just to be clear, because 4 to 6 turns per day, I mean, all that's happened in the past and has been proven to be unnecessary. But when I say faster, I mean, more toward 1 turn per day versus like a turn per week or something like that. And if you follow those rules, you should get the most skeletal expansion possible for the patient that you have. So in this case, if we're shooting for 7 millimeters or so of skeletal expansion, we're going to want to expand, probably at least 10 millimeters, but that may not be feasible depending on where the teeth end up and how we're going to manage that, right? Because the more we expand, the more we have to compensate or decompensate back the lower teeth to get the teeth to fit afterwards. So we're going to get as much as we can, as much as the patient can tolerate with an initial expander. All right, if you don't have a cone beam, there's a lot of different ways you can measure the jaw widths. I'm not a big fan of measuring them at the teeth, like you see here, because the teeth can move and compensate. And so it's not like if we're doing phase 1 treatment, we're typically trying to get the jaws right. All right, if we're going to jump in and do something early, most always, and not always, but most always, we're going to try to get the jaws right. The majority of my phase 1 patients. Sometimes there is just a tooth problem, in which case the jaws are normal and you don't need to worry about it. But if you're going to measure them, I would encourage you one way or another to try and get the measurement of the jaws. So this is we talked about this a couple times ago, Hayes center valvular crest. You can do this even with plaster models. You can cut off the teeth, kind of look where the ridge is, draw a line in the middle, and you can get a pretty decent measurement of how wide the upper jaw is compared to the lower jaw. Don't forget to mark where your first molars are before you cut off the teeth. Okay, so now we go to our composite view, and this is where we're going to put everything together. So when you're doing these presentations, kind of like the last slide where we'll talk about everything, will be on this composite view here. So we've already pointed out all of the concerns and issues that we're having. So now what we're going to do is we're going to decide, should we plan treatment for this patient now, or should we wait and monitor and not do anything until later? So in order to do that, we need to know our problem list, right? So what we're going to do is once we have our problem list derived, we're going to go through each of these problems, and we're going to ask ourselves what question? What's that? What question do we ask ourselves in order to know should we treat this patient now versus should we wait until later and do it in a comprehensive phase? What question should we ask? Yes, I think between the two of you, I heard. Exactly. So if everything on the problem list, if we can correct it later and get just as good of a result, then there's no reason to treat now, right? And so that's how we have to evaluate. It becomes very clear whether or not you're going to recommend treatment based on that question. So we go through it. So crowding, early loss of upper left D. If we don't treat the crowding early loss of upper left D, will something bad or is something bad likely to happen later or no? And sometimes you can be on the fence about it, right? Well, what bad could happen with early loss of upper left D if we don't do anything? Space loss, right? Continued space loss. We already have a little bit, right? So if we have additional space loss and that those molars migrate additionally more forward, that could create an orthodontic challenge, right? Which could cause either one of a couple things. If it was severe, you might have really severe crowding, in which case you would have to possibly extract one of the permanent teeth on that side, or maybe place a TAD and distalize that side. Or if you try to treat it traditionally and you're opening up space on one side, not the other, the maxillary midline might shift. And so if we leave that untreated, there's definitely some things that could happen that could make the result less ideal and or may necessitate additional, more aggressive or more risky treatments later. So when we're looking at space loss of the upper left D, that may be something that we want to address. Now there's lots of ways to address that, right? We could just throw a banding loop on there. So for that problem specifically, at least I'm going to recommend a banding loop or a retainer or some type of something so we don't lose additional space. All right? So there's some idea. We have, okay, we're recommending some sort of phase 1 for that problem. All right, minimal crowding. Any justification for early treatment based on minimal crowding alone? Not really, right? So minimal crowding, typically you can monitor everything. Monitor for impaction of the canines, monitor for teeth coming off track, possibly pull some baby teeth early. So minimal crowding, not really anything you have to do for that. So that eliminate that from your mind as far as whether we treat or not. All right, unilateral posterior crossbite. Okay, so if we don't treat that, what's likely to happen? Okay, so or lack or differentiation of growth in a negative way, right? So that lower jaw can continue to grow off to the side, creating a true skeletal discrepancy and asymmetry that is not going to be able to be corrected later without some form of surgery, okay? So we want to make sure to try and prevent that, and or if it's happened, try to minimize it from happening any further. So there's a justification for treating that, all right? Negative overjet. I think that was actually copied and pasted from the other case, so that doesn't apply to this one. Unilateral posterior crossbite. I copied that twice, apparently. This is a great slide. Congenitally missing teeth. All right, last one. So congenitally missing teeth. Is there any indication to treat the congenitally missing teeth right now? No, we talked about it, right? So they're not ankylosed, there's no good reason to do anything about those now. And again, my recommendation would be to wait. So the problems that we're treating are the posterior unilateral crossbite and the early loss of the upper left D. So what treatment plan would you recommend for this patient? How can we address those concerns? Not a trick question. Yeah, we can expand, right? So we expand the upper jaw, and that corrects our unilateral posterior crossbite. And how do we address the space loss? Did you say a retainer? Good answer. Yes, retainer, right? We're going to put a retainer afterwards, right? So we're going to expand, and then we're going to have retainer. Retainer is going to maintain the width of the maxilla that we obtain via expansion, and it's also, or at least the teeth, and it's also going to prevent space loss going forward, okay? So, yeah, so at this point I would not, and the reason is it's only a millimeter discrepancy, right? So that's, again, something that if we maintain that space, we're not going to have to do later. It's also very complicated to try and distalize, like how would you do it? So it would add complexity to your treatment plan. If you're trying to expand, you know, then it's like, well, you need the anchorage to expand, but then if you're trying to distalize that segment, where's the anchorage coming from? And so it's like, it's not simple to do at this stage, and it doesn't yield you a huge benefit at this stage, because you can recapture that 1 millimeter later, like just as easily, as long as you don't lose more space. So that was the treatment plan that we did, a bonded RPE. Now, because we had a differential loss of one tooth compared to the other side, we went ahead and made the anchorage as close to symmetrical as possible. So we're going to cover the DE6 that we have on the right and the CE6 that we have on the left. We're going to do 38 turns, which is, you know, close to 10 millimeters at the screw, which will get us close to 6 to 7 millimeters of skeletal expansion, depending on how good our anchorage is and how much resistance, skeletal resistance this patient has, which again, we don't know, but she's young, so hopefully not too much. And this is what she looked like 8 months post-treatment. We also ran some cross elastics on the lower sixes, right? So when we're expanding 10 millimeters at the screw, the teeth are moving, you know, the teeth and bones together are moving about 10 millimeters. Well, now, like, neither side's going to fit unless you continue to upright those lower teeth over the bone. So that's what we did, and we took the expander off. This is 8 months post-treatment. So expander was on for about 4 months. You can see that the premolar is now erupting. You can see that the midline, did it do pretty much what we thought it would do? Right, yeah. So we didn't think it was going to shift all the way back based on what we saw in the condyles, but overall I feel like it did a pretty good job. It at least shifted halfway back, right? So that's good. And when you look at the facial photos, the asymmetry of the chin to the right is not near as noticeable as it was, although if you look closely, it still is there, right? And again, that's because that lower jaw has grown slightly to that side. When we look at our Pano, we can see here that we're going to continue to keep an eye on everything, but overall, things are still playing by the rules. We're not seeing any third molars yet develop. We're not seeing any latent premolars start to develop in the area of the missing teeth. And then when we look at the jaw width, this is what tells us what we did, right? So now remember, from 8 to 9, that patient would have grown about another 2/3 of a millimeter, right? So we don't get to take credit for that. But anything above and beyond that 2/3 of a millimeter that she would have normally grown in that year is going to be the effect that we have with the expansion. So when we look at that measurement of the upper jaw now, you can see we're at about 46 millimeters. So we've gotten, you know, quite a significant amount of skeletal expansion, right? So this is great. This is good. This one responded, you know, better than others do, if that makes sense. Now, if you were paying attention to the other jaw width slide I showed you, the width of the lower jaw in the cross section was 45.5, and now it's 44. So what happened? All right, we have our golden ticket answer for the day. Yes, so we're measuring a different part of the lower jaw, but we're not measuring a different part of the upper jaw. So why are we, if we measure the same part of the upper jaw, why are all of a sudden we measuring a different part of the lower jaw? Yeah, the patient was shifting forward, right? So basically what was happening is that both condyles were shifting forward, but the left side a little bit more than the right side. And so when we measured initially, she looked a little bit more class 3 or normal. When we see her jaw relax, she's actually, if anything, a little bit more class 2 tendency because the lower jaw is set back a little bit relative to the upper jaw. So again, we can't take credit for the normal growth, but we can take credit for everything else. So this is the 3D superimposition. This shows the movements that happen. Now, obviously, you know, we can't differentiate growth out of there, but look at the changes, and you can see the blue is where everything went to. So you can see the development of the upper jaw. You can see the left side of the lower jaw is all blue. So again, that was that lower jaw shifting back to the left side. And you can see those changes that happen all the way up into the level of the cheekbones. Yes. 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 That's correct. No, that's basically, yeah, the very, very, very front of the lower first molars. Yeah. But again, if we scroll back to the middle of the first molar, it's going to be 45.5. Yeah, it's not going to change. I mean, lower jaw from 7 to 26 is like a millimeter. So, I mean, you're going to see almost no changes in your serial images on the width of the lower jaw, unless there's like a weird problem or something. And so this is the superimposition of the width here. So you can actually see the changes in the bones. Now, we talked about as the maxilla expands, it typically comes down and forward. Almost always in adult, with adult orthopedic expansion because the resistance is higher. Growing kids, you'll see there's more variation in the changes that happen. So you can see in this case, there's definitely a big change in the vertical component of her growth, right? So you can see here how far down the entire maxillary complex and nasomaxillary complex is coming with the result of the expansion. And then when we look here, you can see that as well, but not quite as much forward movement in her case, right? So pretty much, more straight up and down in this case as far as the changes go. And then also in the smile, if you look back, you'll see that it increased her smile display as well, which adds up with the expansion that we achieved there. This shows the upper jaw, and again, you can see the width. You see the most change in the posterior area, a little bit less in the anterior area in this case. But this also shows, look at the widening of those sinuses and the internal nasal passageways. So this is what contributes to allowing patients to breathe better. Now again, her chief concern wasn't breathing, but if it were, this would be what improves it. As you go through, and the internal, the external nasal valves, everything's going to broaden as those sinuses and the nasomaxillary complex broadens as well. All right, have a great day, guys.